I think we have Sharon Dsouza to tell us about the problems we had with COVID and iBanking.
Good evening, everyone. Good evening, Dr. Maskati and Dr. Vanity and everyone else on the podium. It is an absolute honor to be here and speaking about something that we've really had challenges with during these last 2 years. I'll just share my screen. Are my slides visible?
Perfect.
Yes. So I don't think anyone needs any introduction to what the COVID pandemic is now after these 2 years from the beginning of 2020. But what we may not realize is the extent of the impact that this pandemic has had on so many different aspects of both medical life from the patient point of view, from the doctor point of view, and the allied services that we provide. One of the biggest challenges that has been there as ophthalmologists and eye care professionals is that because of the proximity that we see or do procedures with, there was a lot of fear initially on whether we are at higher risk of developing the infection. So it's no less than a saga. So when the pandemic actually started at the beginning of the pandemic, with the rising cases, there was an announcement for a lockdown allowing only essential services. As the cases increased, as per the directive of the Ministry of Health, Home and Health and Welfare, the iBank Association also made an announcement that it was probably better to halt the iBank services temporarily. Now, the impact of the pandemic was catastrophic on iBanking because obviously once we have to halt the iBanking, the number of eyes that can be collected safely dropped drastically. Unfortunately, that did not translate into the number of patients requiring a transplant. So the gap between the demand and supply, so to speak, increased even more than we know it to exist already. So in continuation with this, of course, during the lockdown period, iBanking came to almost a stop. But once things improved slightly, the All India Ophthalmic Society, along with the iBank Association of India, brought out this consensus statement with guidelines on how to resume the iBanking services slowly. Now, this was a very extensive paper that came out, guidelines, which detailed very, very basic things for ophthalmologists and iBanking professionals on how to resume, right from the care that they need to take, the cleaning facilities that are needed to be available, how long to quarantine the tissue if required, what kind of questions to ask, and what is the screening to be done, and also the risk assessment and how to keep our staff safe. It also listed a number of procedures which we would consider as emergency and thereby could consider doing during this time, and the ones which are probably better to be relegated to a later time. Cleaning of the iBank, as that time it was right at the beginning of the pandemic, and our knowledge of the virus and transmissibility was very limited. So a lot of fear and skepticism as to how we would deal with everything. So it really gave it a lot of detail on how to clean, how to train our staff on the donning and doffing of the PPE, and how to try to keep everyone safe, because that was the priority. One thing which was left up to the discretion of a hospital or its medical director was whether we had to do an RT-PCR or any form of COVID testing on the deceased, and it was left to each person. It also provided an algorithmic approach to how to obtain and handle these tissues in the COVID area. I'm not going to go into detail. Now, what has happened over time is, of course, everyone gradually opened the iBanking services, but there were a lot of challenges to restart. That is because of the uncertainty which surrounded the pandemic at the initial stage, because the probability, we do know that one of the routes of transmission or potential routes of transmission rather, could be the ocular surface because it is a mucosa, although there is no evidence to show what is the percentage of transmissibility. There was also an uncertainty regarding what would be the availability of donors if we started the eye bank. So in terms of the economics of getting your staff back, and also no clarity on what would be the volume of surgeries to be expected. So how much risk to put the staff at to go out, collect the tissues if we do not know how much would be utilized. So the principal responsibility for everyone was to ensure that the eye banking activities and transplants didn't transmit or worsen the pandemic state. And our focus was, of course, on two key groups. So one was our own staff, doctors, and whoever is involved in the eye banking. And the other is the other aspect, other end of the chain, which are the recipient and anyone involved in the recipient treatment center staff, like the transplant center. So a lot of effort goes into trying to keep the staff as safe as possible. And PPE was, of course, a very important part of it. Hats off to all the COVID warriors who, took part in the COVID collection in the peak of the pandemic, because it's not at all easy to go and do these eye collections with the PPE. Of course, training them was a very important part. So safety protocols on how to handle the tissue, how to handle the forms, and how to quarantine was also very important. From the other point of view of trying to keep people safe, the screening form from the phone, when the phone call comes into for the eye call, get the screening questions of history of fever, upper respiratory infections, contact with COVID. Of course, a lot has changed since that first wave, because at that time, questions like travel to an area which had a high number of COVID cases, contact with a COVID person were very relevant. And we all know now that there's very few who have not had COVID or an area which is not COVID affected. So a lot has changed in the last 2 years. Again, the COVID test on the deceased was left, is optional. We do it at our center, but a lot of centers don't. And we still don't know how much of value, or is it absolutely essential. Another very important question that we had to deal with or try to make a decision on was whether to do home-based or voluntary donation collections or a hospital-based retrieval, and each of them has their own pros and cons. So a hospital-based retrieval, initially, again, in the first wave, it was recommended that we restrict to a non-COVID-19 designated hospital. But of course, again, as the numbers increased, I don't think there was a hospital spared, and even an ophthalmic hospitals have been converted to accommodate COVID patients. So that whole concept changed. Of course, still, we do try to avoid patients who've had a history of fever or admitted with pneumonia, ventilated patients, to be on the safer side. A voluntary donation or home-based collections can be a higher risk in the peak of pandemic, and I will discuss how that happens. So if we had to do this, it would probably be better, or the safest bet would be to take supposedly non-related deaths, like a road traffic accident, suicide cases, where at least the death, for sure, is not due to COVID disease. And of course, the same rules apply of avoiding any high-risk characteristics. Unfortunately, SARS-CoV-2 was not the only challenge that we had to face. As I said, just because we stopped collecting eyes, it doesn't mean the problems stopped. And we saw an increasing number of patients coming in with conditions like worse, very terrible corneal ulcers, perforated ulcers, and corneal melt. And they were a challenge to manage. And one reason for this possibly worse presentation could be that many of them had trouble traveling from remote areas, challenge in getting permissions. So there were restrictions traveling across borders, and those did add to the challenges of the pandemic. Now, what were our alternative options in this time when we did not have? So initially, not many eye banks had access to glycerin preserved corneas, and that is an important and very important lesson that we've learned from the first wave. But of course, for small perforations, we had tissue adhesive at hand, Tennant's patch graft, which we could do. Conjunctival hooding was good, but usually is relegated to eyes which do not have so much visual potential, but in extreme situations, you're clutching at straws to try and salvage the globe in whatever way possible. So like our game of snakes and ladders, we keep thinking we're doing better, and then suddenly we're at the bottom of that snake again. So as the pandemic improved, our eye collections also improved. And of course, as in the initial parts of that improvement or recovery, a lot of utilization was for those pending bad emergency cases for therapeutic or tectonic keratoplasties. In the acute stage, we needed the glycerine preserved tissues, but over time, we went back to using our short-term or long-term intermediate preserved tissues. As you can see, the trend, and this is of our eye bank, but it's reflected across eye banks from the country, that the numbers did improve significantly. However, there is a flip side to this quasi-rosy picture as well. And what we found, because from our collections of swabs for RT-PCR, is that as the community spread increased, there were a large number of supposedly asymptomatic patients or who were certified to have died of a non-COVID death, who came positive on a routine RT-PCR test. So it does not mean that we have to do the RT-PCR, but probably when there are a rising number of cases in the community, we need to be a little more careful. So lesson learned from the pandemic, of course, glycerol preservation or long-term preservation is one of the invaluable ones. We have to be prepared to do alternative emergency procedures, very careful screening as much as possible. And there can be still asymptomatic positives. So rising community levels is a very good marker. And at those times, maybe we should reduce the number of home-based collections. And as the decrease in tissue collection, we are, obviously that gap between demand and supply increases. And just like the number of variants of this virus and the pandemic, I think we'll just have to keep thinking of newer ways to deal with these newer challenges. So thank you very much for a patient listening.